Good evening, everyone. People will probably be coming in for a while, so please excuse them and just let them get a seat. We are likely oversold tonight. Welcome to the Baker Institute. I'm Elena Marks. I'm a senior fellow in health policy here, and I'm really excited about tonight's conversation. There's a group of us at Baker within the Center for Health and Biosciences who work on health system reform. And the reason we're doing that is we have a system that is financially unsustainable, inaccessible to too many people, and frankly doesn't produce good health outcomes. In this country, we spend more than $4 trillion a year on health care. We spend way more than other developed countries, and yet our health indicators like life expectancy, maternal and infant mortality rates, obesity rates lag behind other developed countries. And our work is focused on looking for mechanisms to increase the value we're getting out of our system by improving outcomes, putting money where it ought to go, and reducing healthcare costs. We look at how the system is organized, we look at how it's financed, we look at the costs and the benefits, and we're also looking at incentives because all of the actors in the system have incentives and they do what they're paid to do. And so if we want to make changes in what they're doing and how they're doing it, then we need to change the incentives. Tonight, you're going to hear a conversation that will be just amazing between our own Vivian Ho, and those of you who've been around here for a while know Vivian, nationally renowned health economist, has published more papers than I'll ever read, and is sought after by so many reporters and media outlets across the country for her insightful views on what's wrong with our system and how to fix it. She is going to engage with Dr. Ricardo Nuila. And I'm not going to give you much of an intro about him because if you've lived on this planet or in Houston in the last month or so and you turned on the radio or the TV or you looked at the paper, you know who he is. He has been working in our own Harris Health System for more than a decade, and that's our public safety net system. And based on his experience in that system, he's got some really great ideas to contribute to the discussion about how do we change the system we have so that we get better outcomes at better costs. So this should be amazing. Why don't you both come on up, and Vivian, I'll turn it over to you and take it away.
Thanks so much, Elena, and welcome, Ricardo, to the Baker Institute.
Thanks so much for having. This is amazing. Thank you all of you all for coming. This is wonderful.
Yeah, folks, just feel free to come in. You're not going to interrupt us. So let's figure out who's in the audience. All right, to get started.
Let's see.
Do we have any high school students? Okay, don't have any high school. They may still be wandering around in the parking garage trying to find their way.
Yeah.
College students, undergraduates, okay. Graduate students. How many are you in medical school? Okay. Let's see. How many are involved in the healthcare industry in any way whatsoever? Okay, interesting. How many in direct patient care of some sort? Okay, so now you know who you're talking to. How many of you have already read the book? Okay, so many of you have not read the book, so we got to be careful in terms of,
Yeah. Spoilers. No spoilers.
Yeah,
okay.
no spoilers.
I haven't watched Succession either this week, so I don't want it the other way around. I don't want spoilers the other way. So.
Okay. Oh, the newspaper sprung a lot. Oh, okay. Well, we'll see. I think there's going to be something for everyone tonight. So, before we get started talking on the book, your background, okay, I'm not going to say you're the quintessential Houstonian background, but you went to Strake Jesuit for high school. You went away to Georgetown for college, and then Baylor College of Medicine.
And then inbred there at Baylor for medical school, internship, residency, and faculty now.
Yeah.
So yeah.
Okay, but a lot of Houston, so a lot
Right.
of people can relate to that. Okay, so parents, I think a lot of you are going to be relate to me and my teenage son, who he's a sophomore, and despite having a terrific English teacher, he struggles to write. And just to get us started, I'm curious, where did your gift for writing come from, or your desire to write?
I don't think it was a gift at first. It was, I got a D on my first paper at Strake Jesuit.
Oh.
And the teacher, I think I was just like, this is not going to be easy. That helped, to learn that you can't express yourself well, But then in college, I started off as a pre-med in college, and I'm born into a family of doctors, and so that path was like really laid out for me. But then in college, I struggled because I gravitated toward English. And by the end of college, I just decided that I really wanted to write, just because of all of the wonderful teachers that I had in college. And I think of my English major, I'm very proud of that, because I love studying English. I would do it again, right now. I would take English classes right here.
Fascinating. Okay. All right, there you go. So this book, it is ultimately about something larger, but it really is. It's so much of it is around the patients that you met, and there are many. But I'd just like to talk about two. First, Stephen, because he's the kind of gentleman that we may have met.
Yeah.
And particularly, I don't know, sort of in the area we live, I don't know, inside the loop, something like that. But could you talk a little bit about Stephen?
Yeah, Stephen he was a restaurant manager at Fuddruckers. He earned $75,000 a year, and like so many Texans, like so many people, just was like, I've never used the healthcare system, so why should I pay for healthcare? And so he got the lowest plan offered by his employer, which he found out offered very, very little. When he started, at the very beginning of the pandemic, he started to feel a lump on his neck. He was running a fever, and he eventually got to the point where he had to go to the emergency room. He went to the emergency room of a private hospital, and, jumping through the hoops. At first, they even charged him $600 just to sit and wait there. They shuttle him back and forth through different satellite hospitals. Finally, he gets to the point where they've done a CAT scan, and the doctor is informing him of the diagnosis. And the doctor says, yes, you have tonsil cancer. However, and he just, that's like the operative word is however. We can't treat you because you don't have enough insurance. So that is, for somebody like Stephen was all about customer service. I have scenes about how much he loved providing customer service for people. It's a punch in the gut that somebody would say that. He knew that this was just the way that things operate. And then somebody comes into him, he's feeling terrible about it. Somebody comes into his room and says to him, go to the public hospital, go to Ben Taub. And that's something that those of us who have worked at Ben Taub, we hear that story so often. I mean, I just can't tell you how often we hear that story about patients who have been ping-ponged around different places because of their insurance, and then somebody tells them, go to Ben Taub. And so it was, Stephen was a very open person, and he wanted to tell this story. So he gave me permission to give to portray his story in the book.
Yeah, and we won't discuss his whole story. We don't have time to. He was a manager.
Right.
And he paid.
Yeah, he paid for
care.
health insurance, right? He paid for health insurance. He had health insurance, and it simply just wasn't enough. And that's more and more, that's what we're finding is that these gaps are widening. People who didn't feel like they would fall through the gaps are falling through the gaps.
Yeah, and then he he did pay a reasonable
Oh
price
yes,
for
that's right.
his-
So he does receive the care that he needs, which is extensive in the public hospital at Bentab where I work. It includes radiation therapy. It includes, I love that, chemotherapy. We have a radiation oncologist in the front row. That's why she was like, yes, and I was like, yes, okay. It includes chemotherapy. It includes admissions. It includes a very large surgery to like dissect away the tumor. And at the end of the day, because the system, so he did not qualify for the financial assistance that the public hospital system gives. He had to pay out of pocket, okay? And what happens is that a payment plan is derived according to how much he owes. But what he ended up paying for all of that health care was, what, in his words, less than a pickup truck, $40,000. Which for those of us who have been to the hospital or know about, it's just to give you an example, his dad was going through cancer treatments for prostate cancer, and his bill was somewhere in the order of like $500,000 or something, and insurance was covering some, and so his dad owed more out of pocket with insurance than Stephen owed for all of his care. So it was an example of how much, to me, the profit motive of the middleman within healthcare, because these are direct services provided to him, was really making the healthcare costs higher.
Yeah. Okay. Now Roxana is another
Yes.
patient who we're not likely to have encountered. Could you talk about her experience? And
Sure. So Roxana is a person who's from my parents' home country of El Salvador. She came over in the 90s without documents, and at that time she said she walked across the border, and she just like so many immigrant stories, she walked into Houston and had a job the next day here. And she was working at Saks Fifth Avenue for a while, had health insurance through Saks, but then through twists and turns in life was doing like self-employed, doing things like caretaking for, basically for the infirmed, for like the wealthy of Houston's, they're infirm, like elderly and everything, was a personal caretaker. And but she didn't have health insurance, and so she'd started to develop vomiting and weight loss, and she just ignored it because she knew she didn't have health insurance, to the point where when her friend saw her for the first time in 9 months, literally the moment that she laid eyes on her, she was like, I have to take you to the hospital now, because she had lost something like 100 pounds or something like that. She looked vanquished. She took her to a hospital, and after the test showed that she had a tumor that came out of her inferior vena cava, one of the largest veins of the body, and that wrapped around her heart and in her lungs, and in her liver, was causing her heart failure symptoms. So she was in an emergency state at that moment. The only thing that could save her was a surgery to dissect the tumor. She was in Houston, Texas, where, like quite literally, the best surgeon in the world to do those surgeries is here. And she was able to get transferred in order for him to do it. But she suffered an incredible complication that is rare, but it does happen, because to have this surgery, she has to be connected to a cardiopulmonary bypass machine, and when the tumor was incised, it releases cytokines or molecules that made the circulation on her extremities, on her legs and arms, clamp down, so that all of the circulation could be diverted to her vital organs to preserve them. So actually, she woke up and she found that her arms and legs were dead, because they had not gotten circulation during the surgery. Again, it wasn't an error, it was just a complication of the surgery. But what happened is that, interestingly enough, she changed in the eyes of our healthcare system from an emergency patient who could have died, and therefore the hospitals and the doctors could tap into funds to help her through emergency Medicaid into a chronic patient, because now even though she has, I mean, her arms and legs started to become the color of like charcoal. You know, they were dead. It was dry gangrene, all 4 limbs. And so she was no longer emergently ill, and our healthcare system doesn't really incentivize people to take care of the people who are chronically ill. It's about emergency. There are funds for emergencies, and there's even laws and rights for emergencies, but not for chronic. So the hospital had to discharge her, and without a real plan on how to take care of these. In fact, their only plan was just let your arms and legs fall off by themselves. I mean, she even lifted like up her arms to the care staff to say, "You mean like the branches of dead branches of a tree falling off?" You know, and they said they expressed the confusion that is inherent within the healthcare system of America, which is they didn't know how to reconcile chronic care versus, you know, getting her into a place where she could, you know, have this problem taken care of. Well, she ends up finding that there is a public health care system. I don't know what happens outside of Harris County for her. I don't know what happens. We have a public health care system to help her. She was plugged into Harris Health, and she, you know, and well, you'll see what happens when you all read the book, you know. But the point is that, like, I mean, she stuck with me because I don't know what happens with her if she's from one of the surrounding counties or in other counties in Texas or in other counties, because she's undocumented too. So she's explicitly left out of much of the insurances that are, you know, Obamacare and Medicare, Medicaid. So, but yet she is, I mean, I identified with her immediately because she's from El Salvador. I mean, her neighborhoods were, you know, lorded over by gangs for a long time and everything. So she couldn't go back. You know, all these. Anyway, it's very complex, but her story really demonstrated a lot of like those inherent problems within the healthcare system.
Yeah, very compelling story about her, which the reason you're writing this book is to try and find our way to a better way of delivering healthcare.
Yeah.
And do you have any thoughts other than what you expressed in the book? Do you think we're better off with single payer?
I think we need, you know, we need to take seriously that costs are one of the reasons why people don't have access. And I feel like also we need to, and they both go together. If we give, there's strength in numbers, and if we're able to give, you know, universal basic health care to everybody, I think that costs will actually go down. And so, but it's interesting that we have this political struggles against both of these, you know?
Yeah.
And we're stuck in this quagmire where people don't really realize any of this, you know, and because it's polarized and it's politicized. But I think we all feel the costs. I mean, even though I'm insured, I feel the costs, you know, and the stats show that even like this last year, I think 10% more was out of pocket for utilizers of the healthcare system. So we can feel the costs. I also wanted to demonstrate like what it is when people don't have basic universal health care, and what a system that has had to develop in this gap like the Harris Health System can do for people and can do for the community, really.
Yeah. Okay. So your book has lots of terrific numbers. And you mind if I show you some more? Because
I love numbers.
You know, that's what I like to do. So before we move into numbers, just wanted to mention, is Ann Clutterbuck here? Yeah, she's here. And this is the picture from the New York Times review of your book. And it was Ann's she's a former board chair of Harris Health, which, you know, Ben Taub is a part of. And Ann's father was a Life magazine photographer and took the picture here. So it's one of
Wonderful,
those,
right?
it's a small world, isn't it? Okay, so some numbers here. So I've been working with National Academy for State Health Policy, their hospital cost tool, which crunches the numbers from Medicare cost reports. Sorry to make you have to sort of turn around, but what this is the blue bars are the revenues for Harris Health. So that's actually Ben Taub and LBJ combined. And then we've got the three major TMC hospitals, CHI St. Luke's, Houston Methodist, Memorial Hermann. So you see their blue bars, that's a revenue, and then the red bars are their expenses. And the numbers that you see are the difference between revenues and expenses. So Harris Health, the revenue's relatively low, and a good portion of that, minus 1.1 billion, is covered with our property taxes.
Our property tax.
So that's how we make up for it. CHI St. Luke's, this is from fiscal year 2021, so it's different parts of 2021, but there are 2021 numbers in there. Had a minor loss, and you see, Houston Methodist has a 172.7 million profit. Okay, difference between revenue and expenses. And Memorial Hermann Texas Medical Center, $65 million profit. So if we're all wondering why our health insurance premiums are so high.
Right, it's a simple equation, it's like it goes somewhere and it's profit,
Right. And no HCA up here. These are all
Right.
not-for-profit hospitals.
Right.
Okay, so they enjoy a tax advantage.
Yes.
They are not paying taxes to the state or the federal government that might be used to support charity care.
Exactly, yeah.
Medicaid, Medicare, something like that. Okay. Here, we also want to look at the cost, because you were saying that Harris Health provides lower cost care. And so this, when I call this cost per adjusted discharge, I'm only adjusting for inpatient and outpatient. So this does not adjust for patient case mix, how illness severity. But I'll have to say illness severity is pretty high in all. Would you say?
I'd be interested. I mean, I know that we could probably think, because I imagine that illness severity is very high in all of them, but I wonder, I would like to look at how, the comparison, because.
Exactly. Yeah.
But anyway.
Yeah, that's something we can't answer tonight. But although you've got a low income population, what do we know
who
about?
doesn't have preventive care for the most part, and so the illnesses are the first presentation of that, which might drive up the price, because the first time that you're diagnosing something is when the most amount of tests. Anyway.
So you'd be expecting your cost to be
a little
higher,
bit, yeah.
because they
Right.
have more diabetes, more hypertension,
Exactly.
more everything else. I had a conversation with one of the attending physicians at CHI St. Luke's, and it was interesting. He was telling me a lot of their patients get the insurance reimburses based on DRG, and the patient doesn't realize that. So they're sitting there, and they could tell them, okay, we're discharging you, now go get the MRI 2 days later and let us know the results, and then it gets billed, and the patient pays extra. And he goes, a lot of times we'll say, no, we're going to do the MRI here, so you don't have to pay for it. And they'll have patients going, no, I don't want my bill to be any higher. And he goes, don't worry, it's covered, because we're paying for the entire stay.
Yeah,
so
that's
that may
interesting.
be where some of that cost is coming from. All righty, now have a look at this. Fund balance. Fund balance on the Medicare cost report is the mostly, there's other stuff, but it's the accumulated difference between revenues, expenses over time. So it's, it's your checking account that builds up. And Harris Health, 0.8 billion. CHI St. Luke's, 700 million. Houston Methodist, 7.2 billion. Memorial Hermann, 1.3 billion.
Yeah.
So, is there money in the system
Oh, there's a lot of money in the system.
to pay for the people who are not getting health care?
Oh, yeah. But see, that it becomes a different question, right? About whether or not, if Is there money in the system? To me, it's money is the problem of the system, is that it generates money for people, and then therefore the disparities are gonna occur because of that. You know, that's one of the things that my experiences and like reading is that we pay for the most expensive system in the world, and we don't have the outcome. So I mean, the delta is money. Money is the problem of the system, and it makes the incentive so strong that we can't get the effective and efficient care.
Yeah, Medicine Inc. you call it.
Yeah, Medicine Inc. is the term I use for it.
And so Community Health Choice, you know about.
Mm-hmm.
It is the county's managed care organization. So Medicaid, the way it's run in the state, the policies don't come from the state. The state pays private insurers to run these Medicaid programs, and so Elena and Ann and I sit on the board of Community Health Choice, which sells these Medicaid managed plans, and we also sell Obamacare plans. And so here's an example of a county organized system that's in the private sector, and we've expanded out. So we're selling Obamacare plans to self-employed people.
And the profit motive is not there as strongly. Would we say?
Yeah,
can we say that?
We still need to make a profit, because if we want to invest back into the organization and build in the future. But Community Health Choice is paying for the free books and the parking permits for all the students who came tonight.
Oh, that's nice.
And
I can also say something that I have seen. One of the people that I discuss in the book needed a liver transplant, and I have personally seen that Community Health Choice has actually covered people for liver transplant, so that they can move to get a life-saving surgery at a different hospital. And I think it's very interesting. I think that is indicative of something, right?
Mm-hmm. Yeah. And then there are, well, that story could go even further in terms of other people purposely sending patients to Community Health Choice to get them to cover the cost. But that's for another day.
That's a different.
Yeah. But how about a mandate for Harris Health to not just serve? I mean, I'm just throwing this out there.
Yeah.
I don't know if it's the right idea, but a thought, not just to serve the uninsured in Medicaid, but move into the private sector serving private patients. Possibility. I don't know.
Yeah.
Okay, do I have another? Yeah. So we do want to look at quality. All right, so these data come from something called Sage Transparency. You can Google this. All this data is for free. And so these are quality ratings. This is Harris Health. So two different CMS ratings, 3 out of 5, 2 out of 5. And then Quantros is, they do commercial claims. So they look at quality here. So it's not perfect in quality. All right, I'm just going to run through these numbers very quickly. CHI St. Luke's is doing better. Houston Methodist, there's a 5 right there on their overall hospital quality rating, and the Quantros, you can see they're doing well. All right. So, but you mentioned something in your book, and it is true. So you say these quality ratings, one of the ratings might be, are you taking your medications? And should Ben-Taub be punished if the patients have to ride, 2 different buses to get to the pharmacy to buy the meds? And so they're not taking their meds because of the socioeconomic problems that Elena's doing research on.
That's one of the criticisms nationally also is that the standards held for the safety net hospitals, or essential hospitals as they're called, are it's not the same, and I think some of it, what I've enjoyed is that there have been systems that have developed within, for instance, we have a meds to beds program now, which I think is wonderful. We deliver the medications to patients while they're in the hospital, and what's kind of it's the insured patients who are visiting Harris Health, who their insurance company often says they don't cover that, which is very strange, right? But
Wow.
so talk about like what is patient oriented, right? There's nothing better than having your, well, I mean, there's a lot of things better, but you know what I mean. Like it's like in that context, it's like you get the medications right there, you know, all of them filled. But it's interesting that there is like a wedge that is driven because of this, you know, contracts that insurance companies have with pharmacy, all these things, you know.
Yeah.
So,
Yeah.
but yeah, I also, and part of the argument that I have, because I talk about quality and everything, part of the argument that I talk about is that Ben-Taub Hospital is also a level 1 trauma center for Houston, Texas, and the recommendations are you should have a level 1 trauma for every 1 million people in your city. So, and the other level 1 trauma center is right next door, Memorial Hermann. So there's only 2 doing the job for 8, and so naturally we're going to have enormous waiting times. And a lot of a lot of these measurements are weighted according to like wait times, right? So, you know, I think that it's we have to also weigh, you know, we also have to weigh that against like how much is the community putting into the system,
Yeah.
you know, and do we have enough for that? You know?
Excellent point. Yeah. And it blows my mind. There are statistical ways where we could adjust for the socioeconomic status of the patient population, and I don't know why we do it. Now my guess is if you did the adjustment, there still would be a difference. But are we willing to pay twice as much for every single?
And I think that that's like the big one of the crux of the arguments is that, you know, we have to make decisions on where our money is allocated, and how much are we willing to pay for those extra measures of quality, for like a 3 versus a 4, you know? Are we willing to pay more than double, you know? And I think that when we realize, one of my jobs in this book was to demonstrate what that system can give us, right? Just to, at least as a doctor, but also in the experience of the patients and me going through some of the data, right?
Yeah.
So, because I think that the preconception is that we're comparing something that has to be like private healthcare versus is better than public healthcare off the bat, and I think we just don't have any comparison.
Yeah. Okay, so one more graph. No, that was Memorial Hermann, and interestingly, you're very close to Memorial Hermann. But then, yeah. Here's the one more graph. If you look at the payer mix, so Harris Health is up there. I apologize, it's hard for you to see all these colors, but 55% of Harris Health payers charity care, all right? 18% Medicaid. And the only other hospital that's close to that is, well, Memorial Hermann, which has 77% charity care. So that's a lot smaller, but 20% Medicaid, all right? And then, you know, if you're looking at Houston Methodist, the charity care and the Medicaid is just that tiny sliver up at the top.
I mean, shouldn't that be much larger for the tax incentives that they each receive?
Yes. So
Yeah.
excellent point. So the tax benefit that they are receiving for not paying state and federal and local taxes is substantially larger than the charity care that they are receiving. And the fund balance. Now, every hospital needs to have some fund balance in case we have another pandemic that shuts everything down. But, you know, you start looking around at what is being done with that fund balance. It's, you know, I'm guessing a lot of it is being used to build brand new facilities out in growing suburbs to be able to charge higher prices to more people.
Yeah.
As opposed to Harris Health, you're doing some building too, right?
Well, yes, there's some building, like for instance, to have colonoscopy, to have a center where colonoscopies can be, so the wait list can go down for that. Build like clinics, and there's potentially, you know, things that there's ideas out there on how to on how to make the system larger to address it for more people.
So there's certainly things you could spend the money on.
Yes.
To,
Oh yeah.
to take
There's
this.
things that the money can be spent if we.
Okay, so I want to give people time to, the audience time to ask some questions. I'm just going to go through the next part quickly because the important issue is, how do doctors feel about changing the system? Okay, so this is a quote from your book on Medicine Inc., you call it. I once met an ear, nose, throat doctor at a friend's engagement party who described a patient's first visit with him, and all the things you go through, as a loss leader. He just wanted to get patients in the door. So that's what goes on in some cases, not all.
Not all.
Right?
Not all.
By far. Okay, and the opening part of your book, just the imagery. At Ben Taub, when COVID came, we gave oxygen together. We consulted one another when things looked dicey. If transportation was swamped, we wheeled them ourselves to MRI, to special procedures, to the cath lab, even the ICU. How downtrodden we looked when we did this, like beaten dogs. And so you talk later in the book about disaster syndrome, and that's how physicians feel, and it becomes such a tough situation. And then you say opening more medical schools and allowing more foreign medical graduates to work in the United States only places a Band-Aid on a larger problem. Most doctors simply don't like practicing the American style of medicine anymore. And then you quote an editorial from STAT, the increasingly complex web of providers' highly conflicted allegiances to patients, to self, and to employers, and its attendant moral injury may be driving the healthcare ecosystem to a tipping point. I'll come back to that later. So how do we, it would be great if all of our doctors were like you and your colleagues at Ben Taub. But, as Elena said, there are incentives in the system.
Yeah.
Any thoughts on how you and your colleagues sort of come to grips with what we're working in? Do you need someone else to come fix it for you, or do you think you all have an idea of what you
I don't
like?
know. Yeah, I think that the history of it is doctors have had an oversized say in how medicine takes place in the United States. As I write in the book, I had to look all this up. I didn't know this inherently, but I did research, and it's just whenever a universal health insurance was being debated in the United States from the time of 1910 on, these were defeated by doctor lobbies, the ways that the doctor lobbies attacked them was really reminded me of the tactics of what the NRA does right now, and so we do need to recognize that doctors have had a very strong say in how healthcare is performed in this country. Now, I take heart and optimism because I think that those same bodies who were very strong at that time are changing. It's not as homogenous. There's different ideas in there. And even in the debate during Obamacare, the largest group, the American Medical Association, backed some level of universal health care for everybody, right? So I think that doctors will have an enormous say. I think that we are in a situation, however, where a lot of doctors have relinquished that sort of authority to corporate, to the corporate structure. It's like private equity is almost the natural extension of that. You see a lot of doctors groups who just, who have sold to investors who are trying to make money off of this healthcare system. So it's difficult. It's hard to say. I talk in the book about my own experience with this was just through my father. My father was a private practice doctor in Houston as an OB-GYN in the 80s through the 90s. And the example that I give is that when he started his practice, he had two employees, which was a nurse and somebody who was a receptionist. And by the time, like when I was applying to medical school and going through that, he had multiple employees, but 3 were purely dedicated to insurance claims, you know? And one of them happened to be his mother, my grandmother, who's like Chicago-born, Depression era raised, perfect for sticking on insurance companies, actually. Perfect person to get on the insurance companies because will not relent. But that's the, you know, it took me a while to realize that narrative was really, I was seeing that unfold as I was growing up, that it was beating him down. I describe him as like a mom and pop shop versus the corporate McDonald's. And that's really what's happened in American medicine is that it's become so corporate and so bound to that doctors have had to kind of relinquish that. So it's a complex answer. I think that doctors still have a say, and I think they of course have a say, because when you write an order, that's how everything starts, you know? But the position that you're in to write that order there's a whole milieu of things that put you in that position, including who owns the practice, who owns the hospital, you know, and everything. And that's going to be very hard for doctors to navigate. And that's why I think a lot of doctors are deciding to leave the profession. And that's a crisis that we're going to have to see in the next 30 years, how that unfolds out, how that comes to fore. Because right now, so many people are first of all, we're projected to be short by tens of thousands of doctors for all of our needs in terms of for an aging population and in specialty care. But beyond that, people are actually leaving the profession because they're sick of it. And so, you know, I think that it's gonna worsen the disparities if the price of those doctors goes up.
Yeah, yeah. And by the way, the numbers I show you, this is not an attack on physician salaries.
Mm-hmm.
Actually, you know, so when you look at fund balance, we've already taken care of what we're paying the physicians.
Mm-hmm.
So this is other assets that are Medicine Inc.
Yeah, medicine.
Yeah. So I want to leave. We always have. Oh, good. Exactly. We're going to finish exactly at 7 because I know there are lots of people who are looking forward to you signing their books.
That's nice.
But we've got 15 minutes here, and I'd like to open it up to questions. Do we have microphones tonight?
You don't need it. You should be able to hear them.
Yeah. Okay. And I'll let you choose.
Oh, over there. Yes.
Thank you very much for your insights. I'm curious. So, we talk about Medicine Inc.
Yeah.
We talk about private equity, but yet private equity negotiates, physician groups, negotiates with insurance companies, also independently. Insurance companies make millions of billions of dollars. How do you start reconciling that? Because you're showing what the hospital make. What about insurance companies?
Oh, definitely. That's part of my description of Medicine Inc. is all of those major players. Like insurance companies are at the forefront of that, but hospitals, corporations. The thing is that like many of the corporations have started to buy all of these. You know, corporations own in areas not just like the insurances, but also the hospitals, the doctors groups. It's part of the vertical integration, so that it's like every single sort of decision on that tree like is able to be made for profit at some regard. And just to make it clear, I'm not stating that we need to totally take away every profit motive at all, but I think we're at an extreme. We're experiencing the extreme. And so when I talk about private equity, what I'm saying is that, you know, they have identified that it's a pretty it's a place where money can be made pretty, you know, in a systematic way like that, you know. And my concern is also with private equity from like some of the examples that have existed. For instance, in Philadelphia, there was a hospital, Safety Net Hospital, Hahnemann Hospital, that was purchased, basically, that was sold to a private equity company that ended up just cutting staff from the beginning for like patients who are like, you know, already have complex socioeconomic backgrounds. And then it became to the point where the hospital just failed, and then they sold it for land. You know, so it's like when you have an entity that is fully driven for profit, like the way that I imagine so many private equity. I imagine that there could be, you know, different grades of that, but you know, that one in particular, Hahnemann Hospital, I mean, there was just no reconciliation of what they were doing to the community, you know. So
I think it was sold to develop residential luxury condos.
it ended up being a real estate deal, and this is like to a very needy group, and we just have to recognize that is the way that the system works right now, and I think that it's just extreme, and I think it needs to be a bit balanced. Yes.
I had a question about the cost of pharmaceuticals. They're extraordinary in this country versus rest of world.
Yes.
And typically, either in the top 3 or the top 5 of all lobbying expenditures is big pharma. How does that figure into coming up with a more rational, affordable system versus rest of world? Was that in any of the figures you were looking at? Are you addressing it?
I address it in a very kind of like bird's eye view. We happen to have like one of the foremost experts on this right here, like, but I would say in a very kind of bird's eye view is that, I mean, that the pharmaceuticals charge what the market will allow, and so they charge that because we will pay for it at the end of the day, and that's the way to maximize the profit. Now, I think that the solutions of, like, for instance, something like Medicare for All, or something where there's an enormous amount of people who are negotiating and buying, will drive down those costs, you know, and that's what that we since so many of us are, you know, on. I mean, there's Americans who are on individual plans that they're not with in large groups. We're gonna be subject to like those high prices, you know.
Yeah. So clearly you've been following this very closely, and you understand what's going with pharma, and so Ricardo's book, it's not a to
granular
solve the entire problems of the healthcare system. It is about making Ben Taub and systems like that have a larger role. But I will say, in terms of pharma, you know, I think the bottom line is no one is told, they're not reporting their costs, okay? We're told that the R&D is very expensive, that it takes $1 billion to bring a drug to market, but no one audits those results. They're not made clear to the public. I understand it's risky to develop drugs. However, they should be required to report all their costs of their R&D. Then we can figure out what is a fair profit margin, and it could be much higher than things that are much less risky. But if you tell us what the costs are, that's why the Medicare cost reports are so important. Tell us what your costs are so we can give you a fair return, and we can figure out what's the right price for these risky discoveries.
Yes.
I've heard you speak elsewhere about your support for the British healthcare system, and we are all seeing now reports of the strikes by both nursing and now physicians also. Could you bring those things together for us too?
Yeah, that's a great question, and I think that it's, interestingly enough, so if you look at the British system, NHS, like around half of the doctors that are employed are actually like residents or doctors in training, you know, and that's one of the things that I feel is a contrast to the system that I work in, the public healthcare system, where there has been over the last years like much more investment into doctors already in practice working within that system, you know. So for instance, like I can look back at a time where, you know, yes, all the residents were pretty much taking care of a lot of patients at Ben Taub Hospital. Now it's like 75% of the inpatients are doctors like me who have already been in practice. And when a friend who's a nurse in the NHS, who's also an author, she wrote about the NHS in the UK. She came to the system and to Harris Health, and she saw that. She was like, "This looks just like the NHS, except like less lines, you know, like people are not waiting. So and she was speaking with the nurses and everything. So it's, I clearly there's again, I'm not talking about, I admire a lot about the NHS for a lot of different reasons, but I think that it's also, you need to cultivate that, you know, and they needed to give funding and recognize that they needed to hire people that are not just doctors in training to provide that lower healthcare costs for the medical costs. Mm-hmm. Yes.
Thank you for what you're doing. It's fabulous. It's long overdue.
Thank you.
But thank you for being here. Just a point of curiosity, on the cover of your book and on your materials, you don't say doctor. And that's
Yeah.
your voice of authority. So what was your decision to conceal yourself?
That's a great question, and I actually like had a long and like there was family members who were like, what are you doing, you know? But I want the words to carry all of the argument, and so I value this book as like a writer. Like I think that this is written in a way where I don't want the authority to override the argumentation, the prose, the rhetoric. Oh, thank you. No, I thought about it a lot. I mean, literally, like, I care very much. I also think that it's an argument, a good argument. A good argument is a good argument. It doesn't matter who makes it, you know. So, yes.
Thank you very much. First, a couple of quick questions. First, can you shed some light on the politics in the system from
Yeah.
guidelines? Also, can you touched upon HCA? I assume the belly is quite nice, and if you can shed some lights. And also very quickly, when you mentioned the cost of pharma, how come what's his name, GoodRx is able to work in the system? How are they? You know what I mean?
How is GoodRx like really effective?
Yeah, I mean, exactly. I mean, no one does it out of the goodwill, right? I mean,
So I'm going to start just by talking about the politics of I think that my perspective and what I write about is that I find it interesting that within the healthcare system that I work in, the public healthcare system, that I see both like conservative ideals and liberal ideals that are expressed, and that people have those, and that they sort of end up at similar goals, right? Which is the conservative ideal of cost saving. You know, I think that this is, again, my perspective is that I do think that there's a lot of like it hasn't been enough thought about, like perhaps on the left, to say like we really need to save costs. You know, we have to lower costs, but on the other side, I feel like there's like this like this ideal that's more associated with the left about like universal care for everybody. You know, and I just think that you know it's interesting to see that dance and to see people negotiate that in a way that is like, because it's mission driven, you know, it's mission driven. It's like, we're going to try to do it, but it's in the mission of this is like lower cost, like we realize we don't have all of the resources, but we're going to take care of everybody who comes in the doors. And I think that that's just, I mean, I think that requires a lot of just setting your own ideologies aside and negotiating with that. And I think that that's a good model, you know. Do you want to talk about GoodRx a little bit? I know I use GoodRx a lot, but I actually kind of want to learn from you a lot about how, because Mark Cuban owns them, or?
No, he doesn't own GoodRx. He owns a company that is going to try and make, that is selling a lot of low cost drugs for you know, the lowest at cost.
I imagine they just amalgamate purchase.
Okay, so just you know, the major distinction I want to add, you know, leave time for one more question from someone else.
Okay.
But for GoodRx, the major distinction is that, you know, a lot of people are using it, and then the amount that you spend does not go towards your deductible because you're often paying out of pocket. All right, so it's not getting covered on your insurance, and so you're paying more out of pocket, and creates problems.
you are able to do it when a drug which costs, say, several hundred and you pay 20, right? I mean, pure cash. Where's the magic?
It's a crazy system, you know? So there are companies that are selling it at marginal cost, and then there are other ones that just aren't.
Okay.
And you know,
Yeah.
it's the lack of price transparency. Let's one more
more
question,
question,
and I
yes.
think we'll. Yeah.
So earlier you talked about quality in relation to when you showed the 5-star. Could you maybe talk to us a little bit about how we should think about quality as it relates to outcomes?
Yeah, that's a really good question, and you know, because
By the way, this is Lisa Wright, CEO of Community Health Choice. I don't know if you can see.
oh
see
yes,
that
okay,
part.
yes. Well, I mean, I think we still have a lot of work to do to link like actual like what's being measured for quality and get it to actual quality, because I can tell you that it's some of the quality measures. I mean, for instance, like, okay, I'm talking from the front lines of somebody who works in the hospital and who has to deal identifying with sepsis, but the way that it's measured is really doesn't feel like it is getting to the point of what it's trying to measure, right? So I feel, you know, I think that it's a good start to start thinking about like what are these measurements, but they clearly have to be fine-tuned and especially contextualized for the patients, because patients are complex, you know, and they have, you can be looking at one thing about a patient and address one measurement, and then something else like a blood pressure can creep up, and how do you reconcile the quality for that, you know? So it's the best answer that I can give right now is that like I know that it's important, but I think it needs to be really fine-tuned and especially contextualized, especially for populations, people who are dealing with so many other problems that like are manifesting in their health.
And I'll just say, you know, I'm not even sure fine-tuning is going to do it, because there are multiple stories of patients in your book that if they had not gotten any care from Bentag, they would be dead.
Yeah.
And so they would not be in any quality measures because they just wouldn't be there.
That's correct.
So,
that's true.
so on that note, we're gonna. Not all Baker Institute events end like that, but we do want to leave time for Ricardo to sign books. I know many of you are interested in getting a signed copy. So there is a table outside, and Ricardo will be sitting in that, and we'll be delighted. But thank you so much.
Thank
for
you all
coming.
so much for coming. It's wonderful. Thank you all.